The topic is new onset diabetes after renal transplant. I will cover my topic under these headings. And if it comes from the introduction, the term was established by International Consensus Guidelines in 2003. Definition is based on WHO and ADA criteria, and up to one-third of non-diabetic kidney transplant patients develop prediabetes or NODAT by 6 months post-transplant, and NODAT is associated with cardiovascular events like infections and reduced patient survival. So these are the few definitions, starting from the transient post hyperglycemia. It occurs in the immediate post-transplant setting, secondary to the surgical stress or high-dose glucocorticoids. In most cases, it resolves within few weeks after transplant. Now, what is the difference between NODAT and Ptdm? NODAT does not include patients who may have diabetes prior to transplant, which is unrecognized. And the Ptdm is the presence of diabetes after transplantation, irrespective of timing of diagnosis or whether it was present but undetected before transplantation. Ptdm excludes patients with transient post-transplant hyperglycemia. And this terminology, NODAT, has been changed in 2014 by an international consensus meeting to again NODAT to Ptdm, because as many as 10% of the kidney recipients have undiagnosed diabetes mellitus before transplantation. So the Ptdm in various solid organ transplantation ranging from 10 to 40%, and among kidney transplant it is around 10 to 20%, and associated mortality evidence is high. And if you see in the papers prior to 2014, the pre-transplant average incidence of type 2 diabetes on waiting list for transplant is limited, and at 1 year the cumulative incidence is 15 to 30%, and after 1 year there is a decrease in the incidence of the NODAT to 4 to 6%, and 5 to 6 high-fold of NODAT in transplant patients when compared to the patients on waiting list for the transplantation. And another paper in 2016, when the terms again changed to Ptdm, they use a biphasic curve. The maximum cases occur within the 3 months, and first peak is related to surgical stress and immunosuppressive therapy, and second peak after 2 years is mainly related to the classic age and classical risk factor for the diabetes. And the risk factors for the NODAT are from non-modifiable, partially modifiable, and modifiable factors includes mainly the immunosuppressive drugs and obesity. It's mainly the central obesity which is mainly associated with the insulin resistance. And if you see with advancing age, if after age 45 years, there is 2.9 times higher risk of NODAT, and if there is a family history of diabetes, the 7 times higher chances of developing the siblings. The various diabetes suppressants are mainly the concepts, either the insulin resistance or the CNIs. There is mainly the decreased insulin secretions, decreased insulin synthesis, and decreased beta sensitivity. And among glucocorticoids, the mainly issue is the peripheral insulin resistance, insulin release from the beta cells. And this is clearly shows the action of various drugs, that either there is insulin resistance or either there is a decreased insulin release by the beta cells. The mainly glucocorticoids acts by both as well as the sirolimus, and whereas CNIs, there is a decrease in insulin secretion and synthesis. So what is a pathogenesis? It is similar as that of the typical type 2 diabetes mellitus, but the additional factors are the transplant-related drugs, viral infections, and low level of magnesium. All the 2 more new factors, they are introduced in the conventional diabetes, like in the form of increased renal gluconeogenesis and decreased reabsorption of glucose. and neurotransmitter dysfunctions, which are less established in PTDM. The criteria for diagnosis will be same as that of the diabetes. But in the first initial 3 months, keep in one thing in mind, the HbA1c is not recommended for diagnosis for first 3 months because test may not be valid until new hemoglobin has been synthesized and glycated for appropriate period in the diabetogenic post-transplant setting. And in the first 6 months, the first 6 weeks, don't make a formal diagnosis of PTDM because there may be a transient hyperglycemia, and after that, the testing is with oral glucose testing or fasting glucose, and after 3 months, include the criteria of HbA1c. This is something, if you give steroids, what will the glycemic pattern? The maximum rise in sugar will be 2 hours after the lunch. And observational studies shown that afternoon capillary glucose level more than 200 was more sensitive in detecting PTDM within 6 weeks. But this observational study could not be included for the diagnosis of the PTDM, but this is an interesting finding which we all people see, that the maximum rise in blood sugar level is almost around 4 to 5 p.m. after giving the steroids in the morning. What could be the outcome of PTDM among patient survival as well as allograft survival? Both decrease, and there is an increased relative risk of death from cardiovascular disease, which ranges from 1.5 to 3. And but not all studies have shown that the PTDM decreases the allograft survival, and the graft survival at 12 years was around 48% versus 70% in one study. And this graph also beautifully showing that the patients with normal glucose levels, they have better survival as compared to even IGT and PTDM. And almost at 12 years, the survival is just 48% and mortality is around 42%. So complications related to the NODAT, there is a strong evidence that there could be cardiovascular disease, overall graft failure, and mortality. Moderate evidences of neuropathy, financial impact, hyperglycemic crisis, and infections. Weak or conflicting is nephropathy, death-censored graft failure, and there is no evidence related to PTDM on diabetic foot problems, retinopathy, poor quality of life, and speculated diseases associated such as depression, Parkinson's disease, and impotence. How to manage? The first most important thing is screening and prevention, lifestyle modification, pharmacological therapy, and adjustment of the immunosuppressive treatment. Should we do OGT, oral glucose testing, before transplantation in all patients? It is a practice in some centers, but the suggestion is at least perform OGTT in patients with advanced renal failure with having high risk factors like having family history of diabetes mellitus, race in the form of African American and Hispanics, have elevated fasting glucose levels, older than 45 years, have metabolic syndrome with hypertriglyceridemia and hepatitis C infection. And what are the guidelines? Post-transplant screening by KDIGO, screening all non-diabetic kidney transplant patients with fasting plasma glucose, oral glucose testing, and or HbA1c weekly for 4 weeks, every 3 months for 1 year, annually thereafter. And we suggest screening for NODAT with fasting glucose, oral glucose testing, even when there is an increase in dose of CNI, mTOR inhibitors, or corticosteroids. The prevention is the best policy. How you will prevent? With the lifestyle modification, weight control, diet, exercise, and smoking. Dietary referral is important. A low saturated fat, high complex carbohydrate and fiber diet is encouraged, and physical activity of minimum 150 minutes a week is recommended. And this is the first step to get at least 30 to 35 minutes of activity, most or not all of the days, and spend less time on watching TV and playing electronic games. Spend more time on your physical activity. Lifestyle modification is the mainstay of treatment of diabetes for decades in general population, but limited data in transplant patients. Study published in Transplantation 2008 has found active lifestyle modification benefits high-risk transplant patients, but this is a recent study which shows that glycemic benefits versus active versus passive lifestyle intervention does not improve the glucose metabolism, but there is some effect on weight loss. So further studies are needed in for lifestyle modifications in patients with PTDM, and they mainly take up behavioral change technique in this study. So the emphasis is the healthy diet. What is healthy diet? Limit salt, limit cholesterol, calories to achieve or maintain healthy weight, regular physical activity, moderation, variety, and nutrient adequacy. The concept is major intake from the complex carbohydrates, which have more fibers, more vitamin, more minerals, low glycemic index, feel full on fewer diet. And need is to teach and educate the patients on carbohydrate counting, food exchange list, and here the role of dietitian come to tell how much one chapati is equivalent to how much bowl of rice, use of food pyramid, healthy food plate, and it is select the right quantity and right quality of the food, and use of glycemic index and glycemic load is provide a modest additional benefit for glycemic control. And glycemic than 70, moderate 56 to 69, and low is 55 or less. So this is the green area which is we are showing that which is the patients with the diet with low glycemic index or glycemic load is best. If you choose healthy low glycemic index food, at least one at each meal, chances that you are eating a diet that not only keeps blood glucose levels checked but contain balanced amount of carbohydrates, fats, and proteins. No, the next is the pharmacological treatment. The PTDM should be treated with all tools available. The reason is several complications of diabetes are already present because of the uremic milieu in these patients, so they should be aggressively treated. And in the first 1 to 2 months, insulin is the preferred agent of choice. The concept is beta cell rest to preserve the beta cell function in long term. And in a pilot study, it has been found that if you treat it in initially with insulin therapy, there are less chances of PTDM after 1 year, and withdraw the insulin once the insulin dose requirement is less than 20 units. OHA, only few OHA has been tested for safety in patients with organ transplant, and most of the studies are less than 6 months. Glynates and DTP4 inhibitors, they show safety and efficacy. The pioglitazones was appropriate, safe to use in case reports. Metformin lacked safety data in transplant patients. A Cochrane review concluded that evidence for long-term protective effects of glucose-lowering agents or intensive insulin therapy in PTDM is at present very limited. And these are the various glucose-lowering agents. If you see the glimepiride, they increase the cyclosporine levels, and repaglinide and netatinide, their levels increase when they are used with cyclosporine. The upcoming therapy is in the form of SGLT2 inhibitors and GLP-1 agonists. These are the various studies, including a study from India by Shaw 2019, and there are some benefits with use of SGLT2 inhibitors. And the recent study, which is published in Diabetic Care, with a patient total patient 49, and intervention occurred in 24th with a dose of empagliflozin in 10 milligram, and there is a reduction of HbA1c by 1% if it is more than 8. Or the conclusion of the study was it is safe and improved glycemic control in renal transplant recipients with PTDM, but and also reduce the weight. The concerns remains the UTI. And glucagon-like peptide receptors, the limited evidence used in one retrospective study of 17 patients and found to be beneficial. Now comes to the what should be our algorithm in first month of hyperglycemia, and if more than over 50% readings, they are more than 180 milligram, then dietary advice, insulin, and physical activity, and our goals should be fasting sugar less than 126 milligram per deciliter and PP sugar less than 180 milligram per deciliter. And in second month, again, if more than 50% readings, they are more than random sugar 180 milligram, dietary advice considering tapering dose to 5 milligram of prednisolone, low dose tacrolimus, or convert from tacrolimus to cyclosporine, consider oral agents. And in long term, the study for diagnosis HbA1c more than 6.5 and the same treatment, and try and keep one thing in mind, our goal of HbA1c in PTDM is less than 7.5%, not in conventional diabetes where the goal is less than 6.5%. So what initiatives we can take beyond hypoglycemic agents? Either complete withdrawal of the glucocorticoids. The supporting data is retrospective analysis, but RCT have not proved that journal steroid withdrawal prevents PTDM, and in a study, insulin sensitivity does not improve after withdrawal of 5 milligram of steroid dose. Splitting dose of prednisolone 20 milligram daily might elevate glycemia. And another thing is high dose of tacrolimus is more diabetogenic, and observational studies as well as RCT shows PTDM was better from conversion from tacrolimus to cyclosporine. And another study from the heart transplant has shown that substitution of CNI with mTOR inhibitors, everolimus was associated with low incidence of PTDM. So to conclude my talk, the PTDM develop in 10 to 40% of the patients with first year after solid organ transplant. The major risk factors for PTDM are immunosuppressive drugs, post-transplant viral infections, and hypomagnesemia. Although the hypomagnesemia is a responsible factor, but the studies with oral supplementation of magnesium does not improve the PTDM in these patients, and several main issues need to be addressed in future. Effect of lifestyle intervention, more RCTs are required. What is the optimal immunosuppressive regimens in patients who are at risk for PTDM, and large-scale intervention trials on newer hypoglycemic agents like SGLT2 inhibitors and GLP-1 agonists are required, because we want to earn the cardiovascular benefits which are getting from these drugs in conventional diabetes. We want the same cardiovascular benefits from these drugs in PTDM. Thank you very much.